Good Monday morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement here at the University of Kansas Health System, in for Chief Medical Officer Dr. Steve Stites again. We're coming to you from the Dolph Simons Jr. Family Broadcast Studio. Here in studio today is Casey Pickering, the nurse manager for our medical ICU, or one of our medical ICUs. And also joining via Skype is Dr. Branden Comfort, coming to us live from his clinic in the internal medicine offices today. We'll talk a little bit about long haulers, life in the ICU, and probably touch on vaccines, a hot topic for sure. But first, Dr. Dana Hawkinson, our regular and medical director of infection prevention and control, joins us with numbers. So how was the weekend, Dana?
The weekend was okay. Good Monday morning to everybody. I think we're, again, a little bit happy right now compared to, we know that infections continue to rise. We know that in the Kansas City area, there are those vacillations of low numbers and high numbers. I think we're kind of on that high trend right now as far as daily infections. But here at the health system, we have 66 acute infections, with 23 of those in the ICU and 14 on the ventilator. We still do have 56 in that recovery period. So we have about 122 total patients, which I think is a lot better than 180 that we were running at one point. Hays still has, quite a few, 24 patients, 20 of those in the active and 4 in that recovery phase. So they've been kind of holding steady at a plateau as well. We definitely would like to see fewer numbers, but I think it's a lot better than maybe what we could be seeing.
And still, over half of those ICU patients on ventilators, so a pretty
large
significant
proportion.
number. Yeah, pretty sick. I'm sure we'll talk more about that with Casey here in just a bit. But before we do, are there any reporter questions this morning?
Hi, good morning. This is Ellen McNamara with KCTV5.
Hi, Ellen.
Hi. So late last week, there's been so many news stories that we've all been following right now. But late last week, Joe Biden said that when he is in office, he is going to direct, the federal government to release all these doses rather than holding them back. Just what are your thoughts on that? We're starting to hear around the country that some doses have been thrown away. Do you think that this could help? And just what are your thoughts?
Yeah, so I have a handful of things, and then I'm sure we'll also have some commentary from the others here today. First, the concern right now is that these new variants that we've seen and heard so much about from London or from South Africa that are, or at least appear to be, much more transmissible, not more deadly necessarily, but more transmissible, would mean that the sooner that we can get people vaccinated, the better. And so that's really the driver for, should we make a decision to do something different with the doses that are being held back to ensure that we have second doses for those that have received their first. From what I understand, the suggestion now would be that we won't hold doses back, and we will make sure that the supply chain is adequate to ensure second doses for everyone, rather than holding doses for a period of 3 or 4 weeks. So there's some risk there. I totally understand the reason. You're right. We've heard plenty of stories, both regionally and nationally, about doses that are not able to be administered after they're thawed because we don't have enough patients teed up on that given day or in that place to take them. And I think that's the balance to this. We could add a lot of doses and still not vaccinate more people. So lots of moving pieces there. I'm sure Dana or Casey or even and Branden, you may have some thoughts.
Yeah, I think definitely the first part initially, it's certainly the supply issue. So the total number of vaccines for the total number of people that we need to have vaccinated in the United States. And then once you get to those other pieces like you talked about, the supply chain, we certainly don't want to waste vaccine. So making sure that you have enough people in that certain area or in that given time so that when you do take those out of the cold storage, you can use those to vaccinate people. So there are a lot of moving parts. But I think overall, trying to get as many vaccine doses distributed and into the arms of the American public is going to be a good thing. And obviously we are all hoping and waiting for that when people can just walk into their clinician's office or one of these commercial pharmacies that have contracts to be able to get that, just as you could with influenza vaccine.
You know, Casey, I understand you are fully vaccinated. Now see a sticker in the text strings that say I am fully vaccinated, the 100% added to vaccinated. Obviously understanding the importance for you and your staff. I don't know, do you think anything different around this concept of releasing doses quicker?
You know, I've been super impressed that our teams here, I mean, we, even as managers, the folks running our vaccine clinic, when it comes to the thought out vaccines and you know, inevitably some people don't make their appointment or their scheduled time, and when they do that, their messaging, we're reaching out to people literally all day and night about, hey, this person didn't show up because we don't want to waste a single dose, and folks are stepping up and getting it, and that part I think has been really awesome.
And Dr. Comfort, I am sure in your primary care practice, internal medicine, you're getting questions from patients about the same thing. Anything to add?
You know, nothing really to add there. I know that our patients are very excited and interested in getting the vaccine. We get questions literally every day about this. So I think the sooner we can get it into our patients' arms, the better. And they're going to be excited to have that.
Okay. Any other reporter questions this morning? All right. Well, Branden, thanks for making time today before your clinic begins. You've been a big part of the team creating our virtual COVID-19 long-haul clinic, if you will, that we have worked to soft launch over the past week or two, working through some process of establishing this new multidisciplinary clinic. First of all, tell us really a little bit about what the clinic is and why it's special.
Yeah, thank you, Dr. Wild. I appreciate the opportunity to share what we're working on here. This has been a big team, and I think you're going to have the opportunity to hear from other members of the team over the week here. But the truth is, I mean, we're seeing patients every single day in our primary care clinics as well as our specialty clinics across KU who are coming to us with long-term or persistent symptoms of COVID-19, and so really, we needed to figure out a way to better care for these patients. And so we've developed this multidisciplinary COVID clinic. Now, it's not a physical clinic. It's not a standalone clinic per se. But what it is, it's an integrated approach to providing outpatient treatment and care coordination for our patients who are suffering from the long-term sequelae of COVID-19. So in essence, this is going to be an enhanced effort between primary care clinics as well as our key specialty clinics to coordinate and facilitate referrals quickly and efficiently. So we're working with some key specialty clinics here. You know, the pulmonary clinic, I think you're going to hear from Dr. Spikes later this week. She's really been a driving force for this. But we know that lots of our patients are suffering from long-term kind of pulmonary complications. So we definitely want to have our pulmonary clinic involved. But we have representation from cardiology, neurology, psychiatry, physical medicine, rehab, social work, and I'm sure I'm leaving out some, but it really needs to be a true multidisciplinary effort because we know that COVID-19 is affecting nearly every organ system, and it's complex, and we don't have all the answers. So we're going to try to tap into the expertise that we have right here at KU for our patients' benefit.
Absolutely. It's a great example of how we're able to leverage really all of that expertise that we have here in different areas to bring a big, complete picture, if you will, of what's necessary for these patients to continue to improve. You mentioned the different disciplines on the team. How did this really come to be? What was the reason that we needed this clinic?
Well, I mean, to put it the most simply is that we are seeing patients every day that are suffering, and quite frankly, we didn't know exactly what to do with some of these patients. It's complex. This is a new disease. We're kind of learning on the fly, just like we had to learn how to take care of acute COVID. Now we got to learn how to best take care of patients with chronic COVID symptoms. And so we know that, you know, we have a lot of wonderful experts right here, and so we're going to try to tap into that. So if patients are really suffering from pulmonary complications, cough, shortness of breath, those sorts of things, we want to get them to the people in our institution who know the most about that and can help us try to figure this out and to figure out how to best get these patients back to their baseline health. And so really it was just a response to what our patients need. And we're seeing more of this as the numbers have gone up over the last couple of months. Just like we've seen higher numbers in the hospital, we're seeing higher numbers in our clinic that are coming in with these longer term symptoms.
Is there a specific set of symptoms, or are there criteria that you use to identify patients who would be appropriate for the clinic?
Yeah, that's a great question. Thank you for asking that. So we are initially going to try to focus on patients having symptoms longer than 12 weeks. And so now these are patients who we would say have chronic COVID symptoms. Our long haulers, I think, is a term that a lot of people are familiar with. The symptoms that we're seeing are really quite variable. But I think the most common symptom that people are reporting long term is fatigue. And we're not talking about, I'm dragging a little bit today, Dr. Wild. We're talking about debilitating fatigue. People are having a really difficult time getting back to their normal everyday activities, working full time, putting in a full shift, taking care of their family responsibilities and that sort of thing. So fatigue is a big one, and that one's hard to treat. But we're going to, we have some tools. Maybe we can tap into our physical medicine and rehab experts to try to help us with some of those sorts of things. We're seeing cough, shortness of breath, as I mentioned earlier. That's a common one and very distressing for people. They can't get back to their regular activities if you're still, struggling to breathe and that sort of thing. Chest pain is a common one. Anybody who's had COVID-19, especially with pulmonary involvement, they kind of describe this kind of lung burn. And so sometimes that lung burn really lingers on for several weeks. Joint pains, kind of diffuse joint pains, neurocognitive effects. So, I think we're reading more about people who are having kind of this brain fog or just having difficulty concentrating, depression, anxiety. So really, as you can tell, there's a whole variety of symptoms that someone may kind of present with. And oftentimes these have started after they had the COVID-19 infection. And so, we would recommend that you work with your primary care physicians initially, try to figure out kind of which of these symptoms we really need to kind of send to our expert kind of specialty colleagues for further evaluation and treatment.
You described a very wide variety of symptoms. Is there also sort of a range of severity? Are some people coming with mild symptoms and some others still coming with very severe?
Yeah, absolutely. Just like what we're seeing with acute disease, some patients, it is more mild, which is good. And then we have a lot of patients who are having more severe symptoms that are really having significant impacts on their quality of life. So it really is across the board in terms of severity.
And once patients are established as part of this clinic, how long can they expect to be followed? What's the sort of normal course that you're seeing, at least at this point?
Yeah, that's a difficult question for us to answer right now. We'll know more of that as time goes on, but we're gonna follow these patients for as long as it takes. Now, what we've seen is a lot of our patients do tend to get better over time. And that if we're looking for a silver lining here, that really is it. And most patients do get better over time. And we do expect a lot of patients to kind of return to their baseline health characteristics. Even if they have symptoms, for several weeks, we do expect them to get better. But there's going to be this small percent of patients that very well could have symptoms indefinitely. We don't really know for sure. This virus has only been around for, a year or so. So we don't have long-term data on this. So we're going to have to kind of follow this out as long as we need to. But we're not going to abandon our patients. We're going to follow them as long as they need us.
Is this a unique clinic for the Metro? I haven't heard much about this in other places.
To my knowledge, I think it is unique to the Metro, but there are post-COVID clinics popping up across the country, really around the world. I know the United Kingdom, with their National Health Service, has set up a whole series of kind of post-COVID clinics, partly to take care of these patients, partly to learn more about that. And then a lot of academic centers around the country are setting up similar types of clinics.
How would you suggest a patient who feels that they need to be seen in the clinic make their way towards getting themselves an appointment?
So we would recommend really working with your primary care doctor initially to try to help you kind of get through it and connect you to the right specialty providers. Now, we are going to be utilizing nurse navigators. This is something that we'll probably tap into more as this clinic gets developed, where our other providers, maybe from around the metro or something, can call in with our nurse navigators, and they'll be able to connect these patients directly to the appropriate specialty colleagues.
Great, thanks. And one last thing, not so much related to the clinic, but we talk a lot about vaccinations in the inpatient space for those taking care of acutely ill patients. But we know that that's an important part of providing care in the ambulatory space as well. So have you received your first vaccine?
I have received my first vaccine, so it went well. I'm looking forward. I'll get my second vaccine later this week, and so I just appreciate the opportunity to get that vaccine. I'm quite excited about it, and it's going to be very exciting to roll this out to our patients. That's going to be a really big win for us in fighting this pandemic.
Yeah, completely agree. Thanks for that. Stay around. I'm sure we'll have questions for you as we get further in to the conversation. But now I'd like to turn to Casey Pickering for a few minutes. You've really been involved in the inpatient side of things, in the ICU and in triage, really from the beginning here, helping set up a number of units and sort of the rapid response and all of the things that matter when patients are really at their sickest. Tell us a little bit about what that's been like. Not too many people have that experience.
Yeah. Gosh, first, thanks for having me. I'm happy to be here. Yeah, it's definitely been a journey. I set up the first critical care COVID triage back in March, and for folks, I mean, essentially it's an alternative care site, right? So it's 9 additional beds. We make them into ICU beds. I have since opened and closed that space 5 times. It's currently open right now as an addition to my COVID ICU. So 9 more beds. So essentially, instead of running a 14-bed COVID ICU, I'm running a 23-bed COVID ICU with that space. It's been a journey. Every time you think like we're going to close it, maybe this means we're on the brink, we're getting better. My team gets excited. I think we all get excited. And then inevitably it kind of reopens. And certainly with this last influx, October-ish timeframe, it's basically been open since then.
So, and we probably understand, but maybe everyone at home doesn't. Early on in March, we really used this ICU as a way to decide who was COVID positive and who wasn't, when we didn't know as much about the disease and when we didn't have as rapid of turnaround on tests. Sometimes we were waiting a day or two for a test result, even in the hospital. That's where we started, but that's not where we're at with those 9 beds today, correct?
Correct. Yeah, so those folks, it was a way that they could bypass the ED so that really sick people that maybe were COVID, maybe were not, we didn't congest the ED any further. We got them safely out, got them straight up to us. Very, very sick folks. And we would test them all. We would wait for the results. And as soon as we found out negative, positive, then we would send them to the appropriate ICU, with 61 being like our very initial COVID ICU. And it would, I would be remiss if I didn't speak to the fact that they've been doing this since the beginning of this time. So then we would kind of delve them out appropriately, right? And then certainly that need, our testing got better, we got much quicker turnaround, and then it was determined that the need was no longer for that type of triage, it was just for additional ICU beds.
As we've added ICU beds, or needed to add ICU beds for COVID positive patients, we've talked a bit about how those that stay in the ICU have a longer time in the hospital. They're here longer. What's the longest sort of time frame stay, interaction with patients that you and your team have seen?
Yeah, lots of long-term folks. Our longest was 210 days.
Yeah.
And we discharged him on day 210. to LTAC facility to get a little more rehab, get some strength and things like that back. And he was between my unit, the additional beds that I have. He was in those spaces for about 180 to 190 of those 210 days. So, it's really interesting when we first started this, and you all, certainly Dr. Hawkinson remembers, initially when they would meet certain criteria, we would consider these folks COVID recovered. Yeah. And then we really quickly learned that, gosh, that word is just not appropriate or even at all accurate. They met criteria. However, they are so far from recovered. There is still so much going on with them that it just didn't work anymore. Yeah. We had to change our language. Yep. Certainly for some of our folks, not everybody is here 210 days, but many for weeks and weeks.
Lots of things can happen in 210 days. I'm pretty sure there's a special story about one day in that 210 for that patient.
Yeah, not specific to him. We've celebrated a lot of things with folks. Yes, we celebrated a birthday up here with him and surprised him and his wife, and my team did, and we sang and we danced, and it was ridiculous, and we laughed and we cried, and I think many of us need some sort. We need these joyous moments when we can get them. They seem to be few and far between these days. But 210 days, and you get to know somebody pretty dang well, and we got pretty close to him and his wife.
So, obviously, COVID-19 patients have different needs, a different disease than maybe the patient that had been considered normal or average for a medical ICU bed a year ago or 2 years ago. From your perspective and from that of your team, how have patients with COVID-19 been different from the average?
Yeah, I don't even know if we remember what it was like to take care of patients without COVID-19. So loaded question. We probably don't have enough time, but they're very different from their acuity to their complexity to the way that we care for them. So many things. You even think about basics. We predominantly switched to the half-face respirators, and in the ICUs, most people wear the half-face respirators all the time. So you're talking about nurses that are wearing these masks for 12 to 13 hours. You're essentially shouting that the duration of your shift through that. Hearing one another is very hard. I think one of the things that probably isn't talked about enough or often enough, it's so far beyond the medical complexity of these patients, the therapies that we're providing them, their rates of decompensation, how quickly that happens, the proning. We're master proners now. Who would have thought? Which is when we flip these folks to their abdomen rather than laying them on their backs in bed. Despite all the tubes and everything, we still put them on their abdomen to help with their pulmonary function. And then we flip them back. We have a schedule. We're all scheduled out. It takes about 6 to 8 of us, depending on the patient. So there are those clinical things, but then the other things that are really different is the lack of family. And I don't think that any of us ever thought that we were going to be having literal life and death conversations with folks without family present. And then certainly with devices, right? And if you've never had to have a conversation with a family while you're caring for somebody that is dying, and trying to talk to them and explain to them and console them, I think it's hard to understand what this has truly been like, specifically in the ICU settings where these frontline nurses we're doing that every day.
Yep. So things changed in October for your team pretty dramatically. Not only did the volume of patients go up, but also with that came a number of, or an increased number of patients who didn't survive. And both those things have been challenging. I know for you and for your team, how has that really been affecting the team?
So it's more than my team. It's our team here as a health system, and it's certainly the other COVID ICUs and those who are taking care of these patients. Certainly the death in the past couple of weeks has been significantly more than anything that we have seen. I think when it all flushed out just on my unit alone, we ended up losing 9 patients last week. You see it in the faces of the staff. It's interesting with the first dose of the vaccine. There was a lot of joy. Lots of people were really excited about that. It was almost like we kind of forgot how heavy and hard the work was. And then we got that little boost, and then it is completely, the mood has drastically been different as the rates of death have continued to increase. And I don't think any of us ever thought that nearly a year later we would still be here. Myself included, and there just was not a good way to prepare my team, our team, myself for what we were going to face during this. And it's as we kind of get a little bit weary and a little bit tired, certainly the death makes it feel. Sometimes you just, in the day, you feel so defeated because you're doing everything that you can and you're doing everything right, and it doesn't change the outcome, right? And we're used to like saving people's lives and changing outcomes and having positive outcomes here, and I think that is really hard.
What Casey probably wouldn't tell you is that for our nursing staff specifically, as they grow attached to patients and their families, the job does not end when a patient passes away. There's a series of things that her team, and I'm sure she does as well, because she's very much the type to be right in there alongside everyone doing the hard things. But there are things to prepare the body after death that our nursing staff have to do, and those things have increased in volume as well. And she's right. You can see it in the mood and on the faces of the people having to do this. It's not easy. And I think we all know that thank you isn't enough for that work from the patients and their families, and even from all of our team. So if you had the chance, what would you tell yourself in April that you didn't know then that you know now?
Oh gosh. I think we all probably have a list that's like this long of what you wish you would have known. I think I really thought, and our teams thought, it would not still be here. I think that it initially you heard about it and it seemed kind of elusive. It wasn't really here yet, and then it came here, and then you thought surely it's not going to get that bad. And there's the initial kind of adrenaline almost that came with the hype of caring for these patients. I would have certainly reminded myself to continue to have so much grace for myself, for my team, for the people, for all of us, right? For everybody. Like there has to be so much grace, knowing that everybody has so much going on. It's very unique. No one person's journey in this is any better or harder than anybody else's. They're all different, and I just think in the midst of the other craziness that's going on in the world too, I think that's hard. Never did I think that this would be forgotten. Like COVID-19 was the thing, and then the world got even crazier, and then it almost felt like it got forgotten. And certainly for, I'm sure you all as well, people on the front lines, it felt, there was so much initially. Everybody was checking on you. Everybody would ask. I would get texts from people. How are you doing? How's it going? Right? And now people don't ask anymore. And I wish I probably would have encouraged people earlier on to continue asking the questions. If you know healthcare providers, if you love them, if they're family or friends, you need to keep checking on them. I would ask the questions, ask the hard questions, and then be willing to answer. Most of us, it feels too hard and heavy. You don't want to burden anybody by telling them, but certainly if people will ask and take the time to then listen to the response and really just let people talk, I would encourage people to do that. I have a large amount of fear about what the coming down of this is going to look like once we get through, and some of the post-traumatic stress that's going to come, and the way that people have to unpack and process this is going to be a whole different part of this journey.
I couldn't agree more with the thought that you should keep asking, right? Some days, the how are you doing or are you doing okay question is exactly what someone needs. Even if the answer is, I'm hanging in there, the fact that someone asked is important.
Totally.
So thanks for the reminder.
Yeah.
You were one of our first handful, maybe 4 or 5, to receive the vaccine, and I know that you had your second dose last week. How have you been feeling? Any difference between those 2 doses for you?
Yeah, so I feel great. Again, just like the first time everybody asked that question. I know the second dose was harder for a lot of my team as well, right? I had anticipated that. My fiance and I live on a farm. I was super hopeful to get out of some chores this weekend and to maybe not have to do some of that work, just have a little bit, but no, it's been great. Lots of other folks have had things that we would anticipate they would have, right? A little bit, some fatigue, some body aches. Certainly I could feel it in my arm, but that was essentially it. It has been a non-issue. And any of my staff too, and again, you all probably know this, symptoms lasted maybe like 24 hours and then they were totally good to go.
And you were a recipient of the Pfizer vaccine, correct?
Correct, yeah.
Yeah, so we're getting experiences with both. I think we've had, or this week we start maybe with the first handful of our Moderna second dose. And so we'll see if that experience is the same. But for the most part, I think everyone has found it that way. Yeah, maybe the second dose just a little bit harder, but than whatever your first dose was, but definitely not debilitating. So good news. All right, well, Jill, let's get to some questions from the community this morning.
All right. I would say that the number one question has to do with how do they get their people that are suffering from COVID, these long hauler symptoms, how do they get their PCP to get in touch with this virtual clinic, or how do they get with the PCP at this health system?
Yeah.
Okay. Well, Dr. Comfort, I'll let you take that first one on. How does a PCP in the community get in contact with you if they feel they have a patient that would benefit from the clinic?
Yeah, thank you for the question. So to start with, we're going to start by just patients who have an established relationship with KU. We hope to expand that into the community here over the next few weeks. We need to get our systems in place, make sure our workflows are working and that sort of thing. Once that's in place, we'll have a phone number. Our COVID-19 hotline will be the kind of way for people to get in touch with our nurse navigators. If you don't have a primary care doctor and you're looking for one, you can call the main scheduling line here at KU, and they can get you connected with any of our primary care clinics. And so either internal medicine, our family medicine clinics, as well as some of our community-based practices.
Great, and that's an important point, right? If you don't have a PCP and you feel you need one for any reason, and all of us should, please do get connected, even if your normal needs are very, very small, because it does definitely grease the wheels, if you will, for getting access and getting into all of these other resources that we have available for our patients.
Okay, Kathy has a question. She's 69 years old, and she is Dr. Comfort's patient, and she wants to know, how do I get the vaccine?
Yeah, great question. Great question.
Hello, Kathy. We don't know quite yet. So we're going to be communicating with our patients through various channels to try to make sure that they know that we have the vaccine and that we're ready to give it to, whichever groups we're at. And so I think there's going to be things coming out of the health system, is my understanding, for both through my chart, probably through these media briefings, through on the webpage and those sorts of things. And so this will be coordinated really at the system level. And once the health system kind of gives us instructions at our clinic that we can vaccinate, we'll do it as soon as we possibly can.
Yeah, and Kathy, I think the good news for you, if you will, is that the state of Kansas and their plan around distribution has identified that the first patients to receive vaccine will be those 65 and older, regardless of coexisting disease. There's really, really, really good evidence that says that regardless of your risk factors, age really is the most important as it pertains to long-term outcomes, and the outcome, of course, primary outcome being, do I survive or do I not, an active infection. We don't know when that next phase will start. It is labeled as phase 2 in the governor's plan. And we have been told that it is possible, if not likely, that we may still be in phase 1 throughout the winter. No, not exactly sure what that means, but I would say late winter to early spring is when you can expect to look for signals from us, as Dr. Comfort mentioned, through my chart, through the webpage, through these briefings, through all of our ways that we get out to the community, that we'll be able to start patient vaccinations. It's likely when we get there that there will not be enough supply on any given day to meet the demand, and we'll have to schedule several days, if not several weeks out. And so we're working on what that plan looks like as well. But we will definitely let you know. We will have the ability for you to receive that vaccine here somewhere on our campus, whether it's in a primary care office or in a larger scale vaccine clinic, which is probably more likely for a while. But we'll be working through those details, and I think our organizational promises will be ready the second that we're able to. So.
I have people asking about oxygen shortages. It's in the news that there are oxygen shortages in other parts of the country. Are we experiencing that?
We have actually been focused on this from the very, very beginning. So part of our ICU team really working on what resources we have available, and do we have enough oxygen supply? How many days does that supply last? So we've not run into that situation. We've not even really come close, but there are concerns about the supply. There's also concerns about the physics of being able to deliver a larger amount of oxygen. So Casey can maybe talk a little bit more to this, but there's a specific sort of oxygen delivery device called heated high flow, or there are a number of brand names, and it's high concentration of oxygen that is heated and delivered through high flows, meaning lots per minute. So high concentration, large volume through a special device. And normally we couldn't get to those concentrations unless it was with the use of a ventilator or maybe a BiPAP or CPAP machine. But this high flow device allows us to get those high concentrations to patients who aren't on the ventilator. But the downside is it's a lot more oxygen, and when I say a lot, I mean factors of 10 or more, increase in the amount of oxygen that we use and must be delivered throughout the hospital. And so sometimes physics matters there. And maybe 3 or 4 weeks ago, Casey, we were using a lot of those devices. We're not quite so many this week, correct?
Correct. Yeah. There was a time a few weeks ago we thought.
Yeah. We didn't have enough.
We didn't have enough. It's definitely our preferred method prior to intubating and putting a breathing tube in and putting it on a vent to try to get folks. Here, we just kind of call it comfort flow, but again, but essentially it's the heated high flow nasal cannula. And just so folks, I mean, part of when Dr. Wild was talking about the amount, right? Normally on a nasal cannula, you're talking 6 to 8 liters, and part of what we are running through this heated high flow is 60 to 80 and even beyond liters of oxygen to help. So that's in regard to how much we are using, and certainly the frequency was much more a few weeks ago when we had a little bit more of an influx.
Yeah. And as I was talking a little bit about the physics, one of the things you may have heard in this conversation is that the pressure necessary to deliver oxygen to higher floors in buildings has been a problem specifically in California. And so as more and more patients need more and more oxygen, and there's not enough pressure to get that level of oxygen to higher floors in buildings, they've had to transform other areas that are traditionally not patient care in the lobbies, for example, gift shops, cafeterias, to be able to administer oxygen so that they can continue. So there's lots of pieces. A shortage maybe in that we're using more. Not that there's a shortage nationwide of oxygen. It's just that there's the amount that's in the tank in a hospital is being used more quickly. And then these challenges with the physics of actually delivering this degree of oxygen.
The Lawrence Journal World, according to Vicki, reported yesterday that the vaccination effectiveness is only 90 days. Is that right? Because wouldn't we have to get shots more than 2 doses a year?
Yeah. I don't know about that report. I know that some people are talking about that. I don't think we have any evidence to that, and certainly there's no recommendation about repeating a dose at 90 days. We are hoping it lasts until a year. I mean, I think the earliest anybody has talked about maybe getting a booster is a year from the second dose. So right now there's no indication. Again, what we do know, though, is that people can be reinfected with coronavirus, with SARS-CoV-2. So we know that they can also be reinfected with the common cough and cold coronaviruses. We are hoping that with the vaccination, if you've already had infection, number one, it will protect you from disease and severe disease. But if you haven't had it yet, it will protect you from disease and severe disease as well. We assume and believe it's going to be durable, meaning lasting for 6, 9, 12 months, but we just don't know. But I think to say that it it only lasts for 90 days or 3 months, I don't think that's correct. But there are those theories out there, and again, it is still being fully studied, so we need to continue to wait. But most people, including the FDA, CDC, obviously Pfizer and Moderna, are hoping and believing it's going to be more than that 90-day period.
And I think added evidence, as we now have better population-based studies that track individuals over time from an acute infection, innate immunity is more like 8 or 9 or 10 months. So we wouldn't expect that the vaccine would be less necessarily.
And I think it goes to matter to what you are looking at. So if you're just looking at antibody titers, that doesn't necessarily correlate if it gets down to a certain level that you don't have immunity. We have to remember the memory part of our immune system. And by memory, it means that if you come into contact or are re-exposed to that pathogen, that virus, that those memory B cells and T cells will then be able to mobilize a lot easier and mount that immune response a lot quicker than after that first infection.
Isaac wants to know, he said, I've heard of people taking Tylenol to relieve the pain from the post-vaccine symptoms. Because these are part of the immune response, will the pain medication actually diminish the immune response?
Yeah, good question. So Tylenol should really not affect the immune response. There is some theory that sometimes the ibuprofen or naproxen can have some anti-inflammatory effects, but I don't think taking a dose before your vaccination to get prepared for the vaccination, nor after if you are feeling a little bit of pain, I don't think that's going to have a significant impact on developing immunity to the vaccination. I don't know if Dr. Comfort has any other thoughts about that as well.
Did we lose Dr. Comfort?
We have a video feed, but
Sorry, can you guys hear me now?
there you go.
Sorry about that. Yeah, I was just agreeing with Dr. Hawkinson. I have not seen or read any evidence that would suggest that taking Tylenol or ibuprofen is going to lower that immune response.
I mean, understand that you are getting the vaccine with the modified RNA. Your body will take that up. It will transcribe, create those proteins to mount that immune response to get those cells. And taking, the painkiller, whether it's Tylenol or ibuprofen, for 1 or 2 days is not going to affect what's going on down the road 7 days, 10 days, 14 days after that, as your body starts to adapt and identify that piece of the pathogen, that spike protein.
Betsy wants to know, she said, good morning from Topeka. Question, if my husband has gotten both doses of the vaccine and the vaccine is 95% effective, can he still bring COVID home? Is it extremely unlikely he can catch COVID and pass it on? And he does take a shower and change his clothes when getting home. What do you do?
Well, good morning, Betsy. So first, what we know about endpoints for efficacy for these vaccines is that they reduce the likelihood of severe disease. And we don't know if those who are vaccinated can have mild disease and be spreading, or asymptomatic disease and be spreading to those they live with yet. So the best answer I think we can give you to your question of can your husband still bring it home is possibly. We don't know one way or the other for sure yet, and so we would suggest you act like he can. And then as far as what we do when we get home, Dana, I'll let you tell your your rituals.
I never changed my practices when I got home. I mean, I would change out of my clothes when it was time to change out of my clothes. If I'm going to go out for a walk or go to the gym or do anything like that, then but it wasn't getting home and taking off the clothes inside the garage and dumping them directly into the washing machine or anything like that. So none of that practice really changed for me since the start of the pandemic. But I think more to your point, it's important to understand that you can probably still get, even if you're exposed, you can probably still get infected with SARS-CoV-2. You can maybe develop symptoms. You probably won't develop to the severity as if you did not get vaccinated, but the important thing to remember is you may still have the ability to transmit the disease to others. And so it is vitally important to continue to mask and do those things, and really act as if you have not gotten immunity, or especially act if other people around you don't have that immunity yet.
As far as the changing clothes and those things go, I think, good infection prevention practices are always important, and for those who have used sort of that separation between work and home life in the healthcare space before, there's nothing wrong with continuing it. Early on there was a lot of question about, well, what is the amount of time that transmissible viruses can live on surfaces, whether they be fabric or hard surfaces or shoes or things like that. And the reality is the vast majority of transmission has been shown to be via droplet. And it's not that those things are unimportant. You should absolutely clean your hard surfaces and wash your hands and not touch your face. Those are important components here, but not nearly as impactful as say, droplet precautions or droplet spread.
Yeah, I would say certainly do what you feel comfortable with. I felt comfortable in continuing the same practice prior to COVID as I, doing that after COVID. You being in the ICU with all that intense possible exposure, I don't know what your practices were, but anything that you really feel comfortable with. So, Casey.
Yeah, and it just cracks me up that I love that people love to ask this question and they love to talk about it. People want to know, when we change our clothes and when we shower, and I didn't really change too much, other than some basic things that I didn't really do previously, because I am directly in these rooms all the time, in terms of just like wiping my badge down before I get home, making sure I wipe my cell phone. But honestly, those are things I probably should have been doing before, if we're honest. And now I'm just doing, and then when I get home, you shower and go about your day. I never loved to wear my scrubs or things once I'm home for too long anyway, because even pre-COVID, I mean, there's bodily fluids and just things that we don't need to be traipsing around in, right? So, nothing crazy.
Yeah, whatever you feel comfortable with, really.
Last question, because I know that our two guests have to get back to work. So if your COVID infection was acute, will you have a longer immunity than if your infection was not acute?
Mm-hmm. Yeah, I think there's a lot to this question. So acute meaning, you have this acute illness. It's in that 10 days probably. If you're not hospitalized, it's in that 10 days. If you come to the hospital and you don't have to go to the ICU, it's really that 10 days, that acute illness part, and then you recover from that. I think that depends on the severity. We have seen people who have recovered and developed no antibody response, although it's a smaller population or a subpopulation. But they still have T-cell immunity. They have other immune cells to help fight that off. I think it is variable. We don't know what the durability is for those people that have very mild illness but then recover, or those people that have severe illness and recover. We do understand that certainly you would have a higher chance of having a higher peak of antibody titers, probably for a longer duration if you had more severe illness. But again, we don't know necessarily how that correlates with immunity. But also, even if you weren't that ill and didn't have to go to the hospital and you recovered, you still have that memory function of your immunity. So we don't know how that is. I think a lot of people, there is that individuality there. But remember that you do have that memory immune response that will help with whether you got infected or with the vaccination as well. And that is why maybe that 2 doses helps after that initial vaccine, that priming, and then that second dose to really get that immune system boosted.
Great. Well, tomorrow, KDHE Secretary Dr. Lee Norman joins us to answer questions about vaccines and their distribution. He'll be here every Tuesday in January, but his time is limited, so we'll start right off the top with questions for him. Then Dr. Mario Castro will return with news of 2 new trials around monoclonal antibody therapies. He's enrolling patients currently and will share criteria for acceptance and enrollment tomorrow. These monoclonal antibody therapies are proving to be helpful, and this is exciting news for the team still on defense as we fight COVID-19 on both the offensive and defensive fronts. So look forward to that tomorrow. As we wrap up today, Dr. Comfort, any final thoughts?
No, I just appreciate the opportunity, and I just wanted to share just a thank you to Casey and her team. Hearing her story was just truly it was pretty emotional to listen to, and so I have a ton of respect for our ICU teams. I was really appreciative to be able to hear Casey share those stories. So that was just wonderful.
Casey? Final thoughts?
Gosh, thanks, Dr. Comfort. I was excited to hear your story because I was like, great, so people do survive. This is incredible, right? I love that. I would stick to check on your people, ask them, and my only final thought about that is, if it's hard for you to hear them talk about what it's like, you just have to think about what it's like for them to actually be living it and doing it. So continue to have patience and grace with the people around you. Check in on them, ask them how they're doing, and if they give you short answers, I would ask them to tell you more, and let people start to talk about this a little bit more before it's completely over. And thank you so much for having me.
Yeah, thanks for being here.
Yeah, and I'd like to thank both of our guests. They are so vitally important in helping you and your loved ones with the disease. And Casey is on the front lines in that acute process where you are severely ill. And Dr. Comfort is on that back end where you have recovered, but you still have those symptoms and don't feel back to your baseline. So both of these frontline workers are vitally important and will continue to be vitally important as we continue to move through this pandemic.
I agree. Thank you both for what you're doing and of course, for what your teams, as you truly do work in a large team, are doing for our patients. I would echo a little bit of Casey's commentary that we don't get through this unless we get through it together. And in some ways, that's asking, how you doing? Are you doing okay? What can I do to help? And in other ways, that is doing our part, each of us individually, to make sure that we or those we love don't end up needing Casey's ICU team or Dr. Comfort's clinic. A couple of us were talking over the weekend. There is this focus on vaccine as the light at the end of the tunnel. But it feels, with thousands of new cases per day in the Kansas City metro over the past few days, it feels like maybe we're staring at the light of a train coming at us if we don't really get this under control again. And we were worried that would happen. So please remember, we get through this together. Do your part. We know how to do this. We've done it before. So don't forget those pillars of infection prevention and control. Take care of those around you and those you care about, and we will see you back here tomorrow.